day, and I know who I am for real. But thank you very much for the kind words. And welcome everyone, and happy Veterans Day to all of you who have served or your family members who have served. Without you, our way of life would just not be as great as it is. So thank you. I'm very enthusiastic about Veterans Affairs, and in particular, Veterans Health. As Michelle noted, joined the Research Advisory Committee to the Department of Veterans Affairs a few years ago, and it's our role on specific issues to advise a secretary on policy and research questions for the VA to pursue. And in particular, when we think about the Gulf War era, so those soldiers who deployed in theater to Saudi Arabia, to Iraq and Kuwait in 1990 and 1991 and beyond, it's sort of a forgotten era in that we had 800,000 troops deployed, yet the sequelae from exposures experienced in that theater are not well understood. Our ability to collect information at that time was as less a high fidelity as it is today. Yet we have a large cohort of veterans who served in that theater who are experiencing a hardship. I'm very pleased that this year we petitioned the Centers for Disease Control to adopt a new ICD-10 code, which is a diagnosis for Gulf War illness. And it is considered secondary to toxic exposures in the Gulf War. And this really provides a big opportunity for better identifying and treating those veterans who are at need in that cohort. And by adopting this ICD-10 code, it provides validation of Gulf War illness in of itself for both clinicians and patients. It allows for specific referrals and treatments for Gulf War illness. It overall improves the veteran patient experience for Gulf War veterans. It allows us to aggregate the research in Gulf War illness, which right now is somewhat disparate. And then finally, it provides a basis for epidemiological tracking of this cohort of veterans. So all in all, we expect that the CDC will recommend adoption. We expect that this would go into effect April 1st of 2024. So fingers crossed, the public comment period for this has actually expired, but I know that many veterans and advocates did contact CDC to recommend their support for adoption. One of the things that I'm very focused on going forward in my role as a research advisory committee member is access to innovation. And one of the things I'm very frustrated by is the dogma that we experience in federal government and in the Department of VA as to how we get contacted for research, clinical research. So let's just do a thought experiment here. I'm a pharmaceutical executive. I have a company, and we are developing a drug for the potential treatment of post-traumatic stress disorder. So it seems like to me, and I'm not a rocket scientist, as you can tell, there's probably an interesting cohort of patients in the VA system who may benefit from innovative research in post-traumatic stress. But as a private company CEO, for me to engage and set up research to access Department of Veteran Affairs patients, it's extraordinarily clumsy and difficult, and it shouldn't be that hard. And even more so, 55% of all veterans who have served access Department of VA healthcare benefits in some way, shape, or form. Yet, under the current federal register, physicians and clinicians in the VA system are unable to prospectively reach out to a veteran to get them involved in clinical research without prior written consent of that veteran to even be contacted. And if I'm being honest, it's not top of mind for me as a veteran who also has access to the Department of VA healthcare system benefits to go in and sign a form and ask to sign a form to be contacted about things I don't generally think about or even understand. It shouldn't be that hard. And when you go into your private clinician in private practice using commercial insurance, generally speaking, that clinician's always talking to you about clinical trials that they may be involved with that may be of interest to you and may be of potential benefit for you. So one thing that I'm working on is helping to define a new set of rules that we could consider within the VA system and across federal government to allow employees or Veterans Affairs to be contacted for potential innovative research. That seems like an easy fix, but it's going to take a legislative action. This is changing the Federal Register. So it sounds like sort of a mishmash of political soup, and that's probably what it is. But I feel like that's something we can get done over the next period of time. The second area that I'm also very interested is to make it easier working with the Office of Research and Development within the VA. Is there a better way in which we can stand up clinical research within the VA system? As it stands today, as I understand it, we have to have a primary investigator, a principal investigator within the VA and utilize VA infrastructure to run our clinical studies. Yet as a private CEO or commercial CEO, we hire external parties like IQVIA or PPD. These are big international organizations. All they do is run clinical research for hire. They're really, really good at it. Why can't I hire IQVIA just to go into a VA and help the VA organize and run clinical research? It feels like that should be, let's take the best of the best and apply it to the VA system. And again, to enable more research within the VA and access to innovation. So these are some of the things that are top of mind for me when I think about veterans healthcare and addressing the needs of our veterans. And I'll just close on one last thing, and that is the remarkable rate of suicide among veterans, and something that we should never forget and always have sort of on the top of our lips as we talk about veteran health and care for our veterans. So again, I'm available for any questions if that's something you want to do, Michelle, but if not, I'll be online and certainly available in the chat to answer anything. Thank you for the few minutes.
Thank you. And thank you so much for your service and your leadership. And I am certain that you have built a number of advocates here, and your grassroots are growing in terms of those two key important issues. And again, to recap, it's really the challenge of being able to reach out directly to veterans who may not have earlier opted in to be contacted for research. And then again, to simplify the process and take some of the onus and leverage contract research organizations that Tom referenced. So again, I am sure that you have advocates that you have built here. So any questions for Tom before we start the panel discussion?
Trisha? I'll jump in. Tom, thank you so much for that. And so sarcoidosis is the disease that we represent. Obviously, you probably know that sarcoidosis is very impactful for the veteran population, especially the Gulf War veteran population. And you know, we are very interested in trying to, we know about 25,000 veterans and probably more are living with sarcoidosis. And are impacted from the burn pits and other exposures. And one of the things that we have found very challenging, in addition to the research, because as we are trying to move research forward, that is everything you said was 100% on scale. But in addition to that, one of the challenges we have is getting them connected with within our communities and finding ways. We've been building out mechanisms for support around the country, but getting into those VAs to get those support groups stood up or engaging or making them, giving them access to connections to our patient advocacy organizations has been particularly challenging for all the reasons that you mentioned similarly in research. And thinking about how we can combine that and bring that together, I think would be, you know, really helpful for veterans that are living not only with all the complexities of you know, having served and the exposures that come with that, but also this rare and complex disease. So just wanted to throw that into the mix as something that we're trying to navigate ourselves and looking for ways to do, and would love to continue that conversation.
So Tricia, thank you for that. And what I would encourage any of you who are advocacy organizations representing, like you said, a meaningful cohort of veterans, 25,000 living with sarcoidosis. I think that, with the PACT Act, we've seen much better adjudication of veterans benefit claims. And when we think about probables, for these veterans to access VA benefits and compensation. I think that what's really important, though, especially if you have a substantial cohort, at least from the Gulf War era, is to engage with the Research Advisory Committee. And the way you do that is through a veteran engagement session. So we hold these in conjunction with our Research Advisory Committee meetings, usually the day before. This is a 2 or 3 hour sort of open mic session with members of the committee. We are reconstituting that committee, reconfiguring, I should say, so that we primarily have only veterans who are on the committee serve on the Veteran Engagement Committee, as well as a few of the researchers. So I think I think your point's spot on. How do we stand up advocacy and support groups in regional VAs in an effective way? And I think that's a really important challenge that we'd like to hear about during the veterans engagement session, and then bring that advice forward to the secretary.
Excellent point, Tricia, and thanks so much, Tom. It's one of the great things about our coffee chat sessions is we make new connections and folks find new opportunities. So I'm glad you asked that, Tricia. Why don't we go ahead and start? Oh, sorry, Raisa, go ahead.
I do have a question. I'm engaged in a few projects with some VFWs here in Florida. What will be the best? Do you have any literature, something that I can use in order to present these projects over to them?
So the projects I described are not sort of formal projects yet. These are things that are important to me that I've brought forward to the Research Advisory Committee. I did meet with Congressman Seth Moulton, who does sit on the Veterans Affairs Committee in Congress. He's my local congressman here in Massachusetts, and talk to him about potentially sponsoring this effort to help us move forward with changing the Federal Register for notification for clinical trials. So that's a very nascent project, as is understanding the complexity of clinical research within the VA and making that more accessible to innovative research, especially from the private sector. So I don't have any information on that, but as far as the veteran engagement sessions, I'll post a link in the chat here in a moment to the Gulf War Research Advisory Committee, and from there you can see the schedule of events over the next 12 months.
Okay. And I'm sure we can share that information more broadly too, Tom. So thank you so much. Excellent. All right. Well, this has been a great start to the conversation. I'm going to turn to Karen Rudicelli to first start us off, just to tell us a little bit about the Military Officers Association of America. We'll post your biographical sketch in the chat. So really would love to hear from you, Karen. Thank you to you and your family for the sacrifices you have made as a military family. Karen has worked with us before in the coffee chat, so we're just great to see you again, and would love to hear more about the Military Officers Association of America.
Great. Yeah, thanks. And thanks for having me today. Again, my name's Karen Rudicelli. I work in the Government Relations Department at the Military Officers Association of America. We are a membership organization that is comprised of over 360,000 current and former military officers, representing all of the uniformed services. But although we are our membership is comprised of officers, we advocate on behalf of the entire military community. So that's something important to keep in mind. And I would suggest that most of the issues that we work on tend to affect junior currently serving families the most, because they are in the thick of service and they often have the limited financial resources to solve their problems. And you know, that the other thing I would point out is my job at MOA focuses on DoD healthcare and the TRICARE benefit. So and that is used by currently serving families, including the service member, military retirees and their families, and survivors. So that's the community that I'm advocating on behalf of. I guess I just wanted to start out with a little bit about how I came to this work. When I married my husband in 2002, you know, we were a nation at war. So I understood that being a military family, you know, my husband would be deploying, he'd be facing combat. That's something we understood. I didn't know much about the military at that time, but I did understand that there would be a lot of moving involved, geographic moves. And I also, you know, understood that my career would probably be impacted, that between the deployments and the moves, it was going to be very tough to maintain the marketing career that I had had for about 12 years. And that definitely turned out to be the case. What really took me by surprise as a military spouse were the difficulties that I had in accessing healthcare, not only for myself, but also for my kids. And, you know, I was fortunate enough in 2019 to collaborate with the Children's Hospital of Philadelphia Policy Lab on a research study looking at military family access to care for children. And that study basically confirmed that my anecdotal experiences were not unique to me. But that military families reported less accessible and less responsive healthcare than the general population. And on the whole, their experiences kind of lined up with families on Medicaid. And that was something that was, I would say, not surprising given my experiences as a military family, as an FRG leader who kind of had visibility to a lot of the problems that military families faced, and then as an advocate in this space. So as I said, my work at MOA is really focused on addressing a lot of the challenges that these families face. And you'd probably be surprised to hear that a lot of them are very, very basic. You know, I want to start by acknowledging that the military lifestyle certainly affects those CHOP study results. I mean, when you move around a lot, you are by definition sacrificing continuity of care. Any hassle that you might have in wait times as a new patient or getting pre-authorizations, all of that has to be redone over and over. So part of that feeds into what we're seeing in terms of military family experiences with healthcare. But I think the system also has some responsibility here. The military health system is very complex. There is a direct care system of military hospitals and clinics. About 80% of military family members get their care at these military treatment facilities, or MTFs. That system has a lot of variability across it. And it's also important to remember that that system, the primary mission for MTFs is readiness. They need to keep service members ready to deploy at any time, and they need to keep uniformed medical providers also ready to deploy and provide care in the operational environment. So I think sometimes that leads to a lack of focus on the patient experience. And I would sum that up by saying, you know, families face inconveniences that can be crushing at some times. And I have encountered many families and service members who have faced insurmountable barriers to getting the care that they need. And there is just no good way for them to escalate these issues and get them resolved. So I think that that system plays a part. And I want to say the folks at DoD are very dedicated, but they've got a really tough mission. I think any medical system has challenges managing demand that can vary greatly. And then within the DoD system, you also have providers that are not reliably there. I mean, if they're deployed or if they're in training missions, Your medical providers are also a variable. So it's a tough challenge that they have, but something that we think needs to be addressed. And then finally, TRICARE policy. So TRICARE is the system that works kind of like health insurance, although it's not insurance. It allows service members and their families to access care out in the civilian sector through a network of providers. And again, it acts very much like health insurance. It is governed by its own set of statute, though. And so in order for TRICARE to evolve, to keep up with emerging technology or changing treatment protocols, it often requires an act of Congress to make those changes. And that can be a very lengthy process. As an example, TRICARE still lags the ACA requirements for zero copay contraception and young adult coverage. These are things that we've been trying to get addressed since the ACA was passed more than a decade ago, but we are still, working toward those goals. The second thing about TRICARE is that the network of providers really relies on provider patriotism to participate. TRICARE reimbursements are lower than Medicare. The contractors are incentivized to try to negotiate reimbursements that go below Medicare rates. And as a result, a lot of the providers are, TRICARE patients are not profitable for them at all. And what we've seen in the last few years since COVID is really what I would consider to be an implosion of the networks happening in certain markets as providers who are facing the same challenges related to inflation as the rest of us try to rebalance their patient loads to commercial payers. There's a market in upstate New York around Fort Drum, which is the most frequently deployed division in the Army up there, where three of the four pediatric practices have left the TRICARE network in the last few months. There is one pediatrician in the Fort Drum area to treat military kids outside of the MTF. But that is a market that used to rely heavily on civilian care to take care of military families. So that's a huge priority for MOA in the upcoming year. So as I said, these are kind of basic things that we're working on, but MOA kind of focuses on buttressing kind of the foundation of the benefit, issues that affect almost every person that uses TRICARE. And then we get involved through coalitions on more niche issues like pediatric care. We line up with the TRICARE for Kids Coalition. So I'm happy to address any questions you might have or wait till the end. Thank you.
Thanks. Well, why don't we go ahead and move on to our next speakers, and then we'll kind of take some questions at the end, unless there's anything.
Can I just ask one quick question? Karen, who is the pediatrician?
Who is the pediatrician?
Who is it?
He's at the Carthage area pediatric clinic. His last name starts with a G. It's Italian, like Stefania or something.
My brother's a pediatrician up there.
Oh, okay.
Let's talk.
Yeah, I'd be happy to talk with you. That would be wonderful. Thank you.
Okay. Sorry, Michelle.
It's okay. No, it's great opportunity. So thanks so much, Karen. So I'll turn to Lindsay. It's nice to meet you. Having read your biographical sketch, you are, as I mentioned earlier, you are superhuman. Thank you so much for your service to our country. Would love for you to share with us more about the Minority Veterans of America and how you were inspired to start this organization.
Yeah, thank you for having me. And I promise I'm mere mortal. I even have a cold right now, if that's any indication. So I'm really glad to be here with you all today. I'm Lindsay. I use they, them pronouns. I am a trans non-binary veteran of the U.S. Navy. I'm also third generation military. My mom was also a Navy veteran. She's a single parent. My grandfather too many people in my family. I've just spent all morning. We're mostly Navy. We have a few Air Force folks. Go Navy. We don't talk about the Air Force that much, but it's an inner rivalry. So I am the co-founder to be clear. I have a co-founder out of Seattle, Washington, of Minority Vets. We started in 2017 out of Seattle, Washington. Myself and my co-founder, Catherine Pratt, who is a Korean American woman veteran that was also a student at the University of Washington, go Huskies. So we started in 2017 in what was a really challenging time for the communities that we serve. So we were seeing the first challenges to reproductive health care in our country that we'd seen in most of our times. And we were seeing bans on Muslims traveling to the United States. We also saw the military trans ban, which deeply impacted the communities that we serve via tweet. And we started 12 days after. We came together. I was working with student veterans, I ran an American Legion post, and realized that the communities that we were building were very exclusive and exclusionary. And so we were really set out to create this intersectional movement of minority veterans coming together on the issues and challenges of race, gender, sexual orientation, and religion, all recognizing that there were organizations that served many of these communities, but they were very small. So when you look at the veteran community, you're looking at 18 to 20 million people, when LGBTQ veterans about 1 million, probably more because there's no data. 2 million of our community are women, 5.5 million are racial and ethnic minorities. But when you break that down by race, there's actually even fewer and fewer and fewer. And so what we were seeing was that the community was not getting their needs addressed at the same time as our voices were kind of being drowned out as not relevant to the veteran conversation, or were not enough people to matter. And so what we did was we created what we think is the first intersectional movement of minority veterans. So I obviously can't verify that because we don't know everybody. So we created this intersectional movement really to first create community belonging, because many of us didn't belong to the community. Like, we felt outside, we were harassed or discriminated against in different organizations in different communities, and also to turn our voices towards a larger equity problem and challenge and addressing those equity issues that we had. So I like to say that we are an organization that works on the here and now, addressing the critical needs of our community through everything from leadership development training to food distribution, and also working together to build a grassroots movement towards equity for the future, so that our communities in the future don't have to experience the things that we did, and to truly get justice for the issues and challenges that have happened in the past. And so we started out as 2 people in a text message, because we are millennials after all. We turned into 5 people in my living room working on trying to build this organization. Now we're just over 3,000 members around the country and world. So thank you for having me. Really excited to be here.
Thank you so much. Really appreciate hearing from you. So we will turn now to Mark Gibbons, President, CEO of Retire State. Mark, you have been with us for each of our 4 Veterans Day special coffee chats. Thank you so much for being here, and would really like to hear about your service experience and your continued experience with VA healthcare. And I know you have a personal story to share there.
Right. Thank you again. I appreciate coming back every year. The veterans, of course, veterans issues is very near and dear to my heart. Tom, I want to say thank you for the work you're doing, especially helping the veterans. And if we can figure out how we can work with veterans that have PTSD, that'll be a tremendous plus. And I'll talk about that later on. So our nation's veterans face a host of issues once they leave the service, and despite no longer being in the field of duty, they still face danger. Apart from the immediate physical handicaps left by serving, such as wounds incurred while in active service, veterans can also develop a battery of illnesses, handicaps, and other psychological problems as a result of their time in the military. Exposure to chemicals, such as the burn pits, or like in the Gulf War, flying through the oil fields, the oil fires constantly. Use of military equipment as well takes a toll on military life, and the body means veterans are prone to being diagnosed with life-altering diseases and afflictions later in life, sometimes even after decades after leaving the service. The issue, though, that's close to me right now is mental health is also a common worry amongst them as civilian life after military can be awful trying. PTSD, like you talked about, Tom, depression, anxiety, concentration issues are all prevalent in veterans demographics, which leads to severe consequences for those afflicted. Suicide rates are at an all-time high. Just recently, one of my classmates from high school, her son-in-law, who just has been out of the service 5 years, was struggling with PTSD and depression, and he took his own life, leaving behind a 5-year-old and a 3-year-old daughter and a young wife. So the struggle's real, and if we can figure out how we can talk to these veterans, let them know they're not abandoned, we still do care. They made a commitment to us, to our country. We need to honor that commitment to them and give them the help that they need. I know strides have been made and suicide hotlines and things like that, but it's not nearly enough. We need to better understand PTSD, the exclusion, like Lindsay said. Everyone served. It doesn't matter what you do or who you are. You all served, and you're still a service member, and you should be recognized as a service member, period. When I talk to different physicians around the country and talk about veterans issues, I say veteran and they automatically think male. Well, how many women veterans do we have out there? And that shows in the care that they receive. The VA has done great things, and as a male, I can go into a VA and I can get treated from anything from A to Z there in the facility. But as a woman, you get referred out because we don't have the right physicians on staff. So how do we answer a lot of those questions? So that is another thing that we deal with. Again, my main issue right now is how do we address the mental health crisis, especially for the veterans. There's so many that are homeless. And when someone comes to help them, they don't understand that there is a mental illness that's there. They just think they're somebody, but they were a hero. They're somebody that served in this country, and we need to recognize that and help them. Again, for Lindsay, I have one more message for you. Go Army, beat Navy. And that's coming up. And Tricia, you were talking about, how do we engage? What we do at Retire Safe is to engage with the VA. I go out more at a grassroots level, and I contact like the Silver Wings of San Antonio or the VFWs or the American Legions. And I go to them and talk to them about finding out what issues they're encountering. How do they navigate the system of the VA to get in? I mean, I'm somewhat competent on the computer, but I'll be damned if I can navigate the VA healthcare system website. So there's a lot of groups out there that have learned these tricks, and we just need to go out and talk to them and have them help us engage with the VA and use strength in numbers. So those are some of the things that we do at Retire Safe when we go out in the field and talk to the seniors. A lot of them are veterans, and they're having the issue. So not only are they in Medicare, but they're also, VA veterans, and they are receiving care there. I go to the VA hospital once a year for testing, and not once have I seen the same physician since I've been there, and I've been going for 10 plus years now. And but the care that I do get when I am there is quality. It's just getting in and waiting. And I could only imagine what it's like for a female veteran. You wait and wait and wait. You get excited. You finally have an appointment. You go to the VA hospital. It's, oh, we can't help that issue here. We're going to have to refer you to an outside hospital, and you're back on a waiting list again. We don't need that. We need equal care for everybody. So Michelle, that's where I'm at.
Thanks so much for sharing. Do you have data, or does anyone have data on sort of wait times for? So I'm thinking about your colleague Mark, waiting times to get in for a mental health visit versus for another type of medical issue.
I don't have any current data, Michelle. I know that with the new legislations and things that are movements are going on. I know mental health patients have kind of jumped up, but I don't know what the actual wait time is. I don't know if Karen, if you have heard of anything.
On VA wait times, was that?
Yes.
I have not at this point, no. I think it's been helped by the community care networks, but which kind of provides a little bit of a relief valve, but I don't know any of the specifics on wait times.
I have I can probably, I'm sorry, I can probably
Okay.
speak on that a little bit. Here in Florida, one of the things that we notice, it takes about the wait time can vary between 2 to 3 months before you can be seen.
And that's for mental health services or for any medical?
Mental health.
Thanks for that. So it's an important follow-up, certainly. And certainly it sounds like something Tom is also working on. So, but thanks for sharing that.
I
It's
just
always-
dropped an article in the chat too that has different types of appointment types and different region geographic locations, because it does depend on which business you're in, which hospital you go to, all of those types of things. So there's some data and stats in there.
Great,
Thank you.
thank you. So I guess one question I have in particular, I think for Karen, but for everyone, you talked about the VA, we've talked about TRICARE, talked about community networks. Where's there a one-stop shop, or is there some kind of a resource that patient groups can share with either active duty, retirees, veterans, that kind of helps them navigate how they access into care?
I'll start on that one. I would say, unfortunately, no. There's not, and in fact, there are a lot of veterans who are eligible for care both in the VA and through TRICARE, and the level of confusion out there about how those programs interact, what happens to your eligibility for one if you're using the other. The answer is nothing, but there is a lot of confusion about that. And I know there have been a lot of attempts to streamline and make more effective the transition from currently serving to veteran status. But in terms of navigating the systems, you would really have to direct people to, I would say, VA patient advocates as well as DoD, the TRICARE website. There's no single one-stop shop to answer your question.
Thanks. So who exactly is eligible for TRICARE? And that would be helpful to understand a little bit more.
Sure. TRICARE covers the currently serving uniformed services service members, their dependents, so their family members, retirees of the uniformed services. So those are typically people who've done at least a 20-year career. But it also can be people who've been medically retired. So they've developed some sort of condition or injury that prevents them from continuing their service. And if they're declared, if they earn a medical retirement, they are covered by TRICARE, and so are their dependents. And then survivors of active duty deaths and survivors of retirees are also covered by TRICARE.
I know that there was a study, a colleague from Novo actually shared this with us, that there's a significant amount of difficulty accessing treatment for obesity-related treatments, so weight management treatments, and resulting in sort of a higher incidence of, I think, sort of premature exits, if you will, due to those requirements. I don't know if Barrett is on or wants to put a link to that report.
Sure, I can share the report. That's a recent report from the American Securities Project, and they were talking about recruitment and retention and military readiness due to the fact that 57% of Americans aged 15 to 25, so prime kind of military recruitment age, are overweight or obese. I'll share the report here, but I'd be curious about your thoughts about, improving military readiness as it relates to obesity.
Actually, I think somebody from that organization might have reached out to me at some point. It was my understanding that by policy, TRICARE was covering some weight loss and obesity treatments, such as medications, that weren't being covered by a lot of other commercial insurance plans. And they were actually, they were coming at it from that perspective. That's what the all volunteer force and readiness. I do know that post-COVID, for service members, obesity has become a bigger problem. So it's definitely something that needs to be addressed. The folks that contacted me were somehow looking to leverage coverage to treat young people, because so many of them are ineligible for service simply based on obesity. So it's definitely something I think that's worth looking into. I understand it is a huge problem. And, I did want to point out, because Lindsay's talk reminded me of this too, military families provide a disproportionate number of service members into military service. It is a family business. My husband's father served. It makes him family member service really impacts propensity to serve. And so when you think about the benefit in general, the TRICARE benefit, and the importance of making sure that military kids are staying healthy, that the families are having a good experience because they're influencers in the recruiting process. We are in a recruiting crisis right now. Most of the services did not meet their recruitment goals. The importance of maintaining this benefit, both so that, military kids are fit for service, but also so that military families can speak highly of their service and of the benefits of service, it really does have a potential to impact the future of the all-volunteer force.
Thank you.
Thank you.
Are there questions for anyone on the panel, or topics folks want to bring up? I know our final speaker, Rick Weidman, unfortunately was unable to get on, so we have a little bit of time. So would love to take any questions or thoughts or ideas that folks may have.
Hello.
Oh, is that Rick? I think that's Rick.
It is.
Oh, great. We're
is.
glad you're here.
I'm so sorry to be so incompetent on this thing.
Even though we went to Colgate University, it's hard for him,
Well, Rick is the Executive Director Emeritus of the Vietnam Veterans of America. Thank you so much for joining us. We were worried we wouldn't be able to bring you on. We've had a great conversation so far, talking about a number of the challenges individuals are facing with regard to access and care, or really, in particular for populations that the VA medical system may not have necessarily a lot of specialists in. So really the question for you, and first, if you'd like to just talk a little bit about your work with Vietnam Veterans of America for your time there, really is to think about how has advocacy for veterans, especially with regard to access to care, evolved over the many years that you have been involved and advocating on behalf of the veteran community.
Well, I fell into it quite by accident, because when I came home from Vietnam, I was stationed at Watson Army Hospital, and that I was on the medical holding ward. It was primarily people who had been torn up in Vietnam, and my advocacy was to make sure that people got what they needed from the doctors at the hospital. The doctors were very good. The question was making sure that people got to their appointments when they needed to get there. And so that was the beginning of it. And then to make sure that they got to the right doctors, and that people were paying attention to their multiplicity of needs. And so that was quite by accident that I fell into that.
And over the course of your advocacy work, I mean, would you say that that the sort of treatment for veterans' ability to access care has improved, worsened? What have you seen in terms of changes over time?
Dramatically improved. There's no question about it. Nobody wanted this when we came home, bluntly. What did they use? The old phrase was redheaded stepchildren. We were not wanted in the VA system, and they didn't make it easy for anything. So you had to really fight like hell to get anything. And that made me mad. That's why we started VVA. That's why when oftentimes I would think about, well, I should go up and do something like earn a decent living, I would get mad all over again because I saw somebody being messed over and get going again. And today it's so much better. It's like night and day, by and large. There are still exceptions where people are being messed over, but by and large, VA is constantly reaching out and trying to do the right thing. The whole corporate culture has changed dramatically. And what changed it really was Vietnam Veterans of America, not the organization, but Vietnam veterans who weren't going to accept baloney.
Thanks so much for sharing that.
What's that again?
Oh, sorry, I go ahead.
Well, people just didn't want to accept being blown off and not getting the care that we needed. And for many years, many of our main problems, first of all, PTSD and then Agent Orange, were poo-pooed, that those aren't real. Well, they are real. They were real and they are today, and toxic exposure is real today. You kind of see the same pattern being repeated over and over and over again. Fortunately, gunshot wound and fragmentation wounds are not the only bad things that can happen to you in combat. And some are unseen killers like toxic exposures. Took us a long time to finally get that through to people, but we never gave up. We're stubborn, if nothing else, and we're stubborn and still are stubborn.
That's important. It's important as an advocate to be so. Any questions for Rick or comments that folks might want to make?
There are 2 questions. Do you want me to read them? I can start with that.
Oh, in the chat.
In the chat, is that okay? So we have one from Courtney Manning from ASP. She was just wondering if there's an opportunity to see and collect feedback from veterans on their health priorities. She says that survey mechanisms and data collection mechanisms that can help stakeholders understand what the largest areas of needs are. And this might be for anyone, any of the speakers.
I think one thing that is interesting is that as part of the PACT Act, the Department of the VA was directed to contract with the National Academy of Sciences for reviewing and assessing the presumptive process. So this is where, as Rick was talking about, when things first started happening with Agent Orange, how do you make that determination in a rigorous way given that a presumptive, a declaration of presumption leads to a significant financial commitment by the Department of VA and commitment of resources. So it's a big deal. It seems like it would be easy, but I think we have to be fair and understand that we're talking about, massive amounts of resources. And so I actually sat through the first public report from the National Academy of Sciences. I think it was maybe 2 months ago. And while it was pretty esoteric and maybe not for those who haven't had at least 3 cups of coffee, I do want to say that they are taking a much more rigorous view on how to view these potential presumptives and arrive at a recommendation to the secretary on a particular condition. I'll give you an example. So as I mentioned, I'm very involved with Gulf War veterans, and we note that in Gulf War veteran cohorts, the rate of sleep apnea is much higher than veterans from the same cohort who are not deployed. So why is that? And so that's a research question we're thinking about at the advisory committee. And how do you look into that and then go forth, if there is potential for causation, go through this process for presumptive determination. So I'll just stop there. Maybe it addresses a portion of the question asked. And I'll just conclude that we all know the inevitable outcome on December 9th here in Boston, where Army will win the Commander-in-Chief's trophy by defeating Navy. So as a former
Yes, yes.
as a former Army football player who played in 4 Army Navy games, I can convincingly tell you that Army will crush Navy. Thank you.
Yes.
Lindsay begs to differ.
Well, my son is an active duty naval officer, so I even tell him that, and he knows.
I mean, history has told us that Army will almost always lose, but that's okay.
I was learning to
baby, your hopes and dreams. I get it.
I'm learning so much about the intra-service rivalries. I see it even on our board, where we have a number of really accomplished board members who are also from the military system. Well, thank you all so much. There is one more question that came into the chat, and I'm not sure who may want to jump in on it, but the question is access to care. How is it different, or what are some of the major differences folks observe in terms of the pharmaceutical formulary in Medicare, TRICARE, or VA? Access to medicine, are folks having significant challenges with that, and if so, in any of those systems more than others?
I will start by saying the TRICARE formulary is very robust. TRICARE covers almost all FDA-approved medications. We are starting to see some erosion of that benefit. Congress recently authorized DoD to eliminate some medications from the formulary if they determine them not to be cost effective. So far DoD has shown some restraint in that area. But it's something we really have to monitor moving forward. There's at least one medication on there right now that I think should be covered on the basis of its coverage in commercial plans and Medicare plans, Medicare Part D plans. I do know, and Rick or Lindsay may be able to speak more knowledgeably about this, but I do understand that the VA's formulary, I think, sometimes can be not as robust, and that can result in transition challenges for people that are on medications as they transition from active duty to veteran status.
I'll jump in just really quickly, not so much specifically on transition from military, but I will say that there's unique medicines that are needed for anywhere ranging from reproductive healthcare, contraceptives, Plan B, all of those things, because VA just in September of last year started offering any type of abortion services. They didn't have any of these medicines in formulary. So when they changed the rules, many formularies were not available in VA facilities. So you actually, one, had to go potentially out of network to like a Walgreens. But when you have states that you can't access that care there, you end up running into this kind of like confluence of issues. So when it comes to contraceptives, there's a lot of issues, especially around access and copays. The other part is on like gender affirming care. When you think about hormone treatments, oftentimes it's spotty for transgender veterans to transition out of service, then get access to their hormones through VA, because they have to go through, again, to the point of moving, you have to go through the whole process of establishing care, finding a doctor who can give you that medicine, finding a doctor who will give you that medicine, or that's qualified to administer hormone treatment. So you end up with some challenges around that. There's also some issues and challenges around HIV and PrEP medication. To be able to access that care, you actually have to go to the infectious disease portion of the hospital, which is super neat. So oftentimes you have people that don't necessarily access their care through VA for things like PrEP. So there's tailored medications and unique challenges that face minority veterans and folks that are not necessarily fully understood by the system to be able to access that care. So medications can be deeply impacted by both Medicare, TRICARE, VA, because they're all built on the same laws and policies that were at best designed without us in mind, and at worst designed to our exclusion. So you see veterans every day trying to navigate these health systems that don't necessarily see them or want to see them. And so whether that be medications, access to care, whether it be doctor's appointment, surgeries, things like that, all of that is kind of built to the exclusion of minority veterans.
Wow, thank you for sharing that. Yeah, that is one of the advocacy issues I know you are working on very much so. So thank you for all of that work. All right, well, we are wrapping up, so I want to give folks an opportunity if there's anything folks want to say other than, certainly feel free to get in touch with us. And Tom kindly put his personal email address in the chat. Thank you all so much for your leadership and again, your service to this country and your advocacy on these really important issues, exposures, gender affirming care, the number of suicides, and certainly mental health. So, but I'll say thank you. And with that, if anybody else wants to weigh in, we'd be happy to hear you. Otherwise, we will let you get to your next Zoom in the box call.
Thank you very much, Michelle. Great leadership.
Thank you.
If you're interested in learning more, about what we do, what we're working on, some of the disparity issues that we are tackling, or at least trying to, I dropped a link in the chat to our policy priorities for the 118th Congress. So please check it out. You can always reach out to us and our team.
Great. And we will send a wrap up after this, and we'll include everything that's in the chat. So thank you all so much. Thank you for weighing in. Thanks, Barrett, for sharing about the report. And we will get you all a recap soon. Thank you, everyone. Take care.
Thank you.
Thank you.